Hello, everyone. Welcome to our panel. I'm Joanna Nealon. If you don't know me, I'm the president of this local league. And I'm very glad you all came out in this, kind of crazy weather. And as you probably all know, because looks like most of you are members, that the league is a very powerful grassroots organization. We were founded in 1920 when women got the vote. And in the 1970s, we decided to invite men to join us. And so now we have about 25% of our members nationally are men. Also, okay, so that's League of Women Voters. It's not just women. It also isn't just voters, because at the last national convention 2 years ago, we voted to lower the age that people could join the league to 16. And of course, you can't vote till you're 18. And also, we took out the word that said citizens. So you don't even have to be a citizen anymore to join. So we become very inclusive. So it's a great organization. We're always looking for new members. We often have programs to educate. That's one of our big functions. Sometimes we testify if necessary, as we did in Harrisburg about redistricting, and we were successful, and hopefully that will hold. And anyway, so now I'm going to introduce our chair, our program chair, Jane Brennan, who is a
Thanks, Joanna, and welcome everybody. This has really been a crazy week for a lot of people without power and kind of living on the edge. Special thanks in organizing this program goes to Olivia Thorne and Rosemarie Halt. I would like to introduce our panel members at this time. To my immediate left is Rosemarie Halt, who is a registered pharmacist and also has a master's degree in public health. She is the Senior Director of Policy at the Maternity Care Coalition. She specializes in health policy, particularly as it emphasizes as it impacts maternity health. Rosemarie is currently on numerous public health committees, including membership on the Executive Planning Committee for the Regional Overdose Prevention Coalition Executive Committee, that's all one title, and the Children and Opioid Crisis Plan of Safe Care Working Group. So, welcome, Rosemarie. And our next panelist is Melissa Patti, who has a master's degree in social work and is a licensed clinical social worker. She's a director of the Safe Start program at Maternity Care Coalition. She specializes in working in maternal child health, specifically in supporting pregnant and parenting women with behavioral health and chronic health issues. Most recently, she's been involved in developing programs around substance abuse issues in babies born with neonatal abstinence syndrome. And you may have seen that article in the Philadelphia Inquirer a couple of weeks ago that addressed that issue. And our third panelist is David McKeighan, who also has a master's degree in social work, and he is the executive director of the Delaware and Chester County Medical Society. David has been involved in numerous committees, including the Delco Heroin Task Force Medical Subcommittee, the Chester County Overdose Task Force, the Regional Overdose Prevention Coalition Executive Committee, and the Delaware County Health Advisory Board. So without further ado, do you need the microphone?
Yes.
Okay. So without further ado, do you need the microphone?
Yep.
Okay. Turn it over to Rosemarie.
Hi, everybody. So what we're going to do first is I'm just going to give you kind of a brief overview of this very complex issue of the opioid epidemic. And I'll be talking about Pennsylvania specific statistics as well as some localized things. But first, I just want to tell you a little bit about Maternity Care Coalition. We were founded in 1980, actually by a directive from Philadelphia City Council, because the infant mortality rate in North Philadelphia was higher than most African countries. So our charge since that time is to address maternal and child health and to improve outcomes for mother and baby. And so we are now in Delaware County, Montgomery County, Bucks County, and Philadelphia, our service area, and we service about 5,000 families a year through 9 different programs. And on the table is a little bit more about the programs that we have, but I'm not going to go into them today. Okay, so the very depressing statistic is that more Pennsylvanians die from opioid overdoses now than fatal vehicle accidents. So in Pennsylvania, that's a big deal. There's 13 people die every day from opioid overdosing. In 2016, there was 4,642 drug-related overdose deaths. That's a 37% increase from 2015. So we're not going in the right direction. In 2016, 5 states had the highest rates of death due to drug overdose, and they were West Virginia, Ohio, New Hampshire, Pennsylvania, and Kentucky. So we're leading the nation, unfortunately. And so this is kind of like a county-by-county view of where the death rates are. And as you can see, if they're in the kind of reddish area, they're higher than the 40 deaths per 100,000. Delaware County is 36.9. We're kind of like in the high middle as far as death rates. And as you look, it is definitely affecting rural areas, particularly on the western part of the state, significantly. But as you can also see, Philadelphia is significantly impacted, and its surrounding counties. So this chart just kind of gives you an idea, because when we say opioids, people feel that it's something very specific, and opioids is a broad category of medications. When we break it down, there's 2 things that we're looking for: prescription opioids, and there are things that could be like Percocet. It's a prescription opioid that most people, morphine is another one that people would be familiar with. There's fentanyl, is another compound that is really, really becoming a major issue. It's an opioid, it's a synthetic opioid, and there's different ones. You might have heard of carfentanil, which is the most deadliest that we have been seeing, with potency so bad, I'll put it that way, that some emergency workers have been exposed by airborne carfentanil, and then have overdosed by that, just inhaling the exposure from treating the patient. That's how potent it is. So it's really becoming a dangerous situation that is becoming a concern, particularly for emergency response. So we're looking at percent reported among 2016, and then we're looking at the percent change. So we're looking at fentanyl is leading a percent change of 130% change in the number of overdoses related to that compound. Prescription opioids were kind of on the increase for probably the last 5 years, but in 2016, and that's probably because more of the prescription drug monitoring has been occurring, that number has actually gone down. And so the percent change in that is only 3%. But overdoses, those of us that work in it, don't happen in just one thing. Oftentimes there's multiple compounds involved. And so they can have other things in it, like benzodiazepines, cocaine, other illicit drugs. So it can be a very complicated picture when we're describing an overdose. So it's not black and white. And it's, we were hoping Dr. Hillman was going to be here today, so I was hoping he could explain more of this, but that's basically in a nutshell. But the medical examiners have their work cut out for them in figuring this all out. Okay, so here's a snapshot of Delaware County, and now we're going to talk about the babies. Okay, so in drug-exposed babies in 2016 by zip code, and the darker purple areas are the higher numbers, and that's 40 to 55 per 100,000. We're looking at a surge in drug-exposed babies. So as you can see, as we go through the years, and sorry, it's chopped off on the bottom there, but we're starting at 2012 and going up to 2016 here, and there's been an increasing rate of babies exposed who have neonatal abstinence syndrome. But there is, as I said, other related symptoms and substances impacting the diagnosis of neonatal abstinence syndrome. And we're going to talk a little bit more about that when we get into it. Okay. Interestingly enough, so I got in Delaware County, we have Crozier Health System are the two primary hospitals that women would deliver in. We've had an 8.7% increase in neonatal abstinence syndrome. That's a significant increase. And the same with Delaware County Memorial. And my statistic didn't come up on there, but I'll get into that when we do our discussion. So what are the two generational impacts of this? In 2012, in Pennsylvania, there was 105 child fatalities or near fatalities. In 2017, that number was 243. And 81% of the children were under 3. And in 2017, in the Southeast region, there were 30 child fatalities and 49 near fatalities. And nationally, 437,500 children were in foster care, and 25% of those were because of parental drug use. In Pennsylvania, and remember we're in the top 5, 16,000 children were in foster care, 55% were taken because of parental drug use. So a much higher number than the national average. So one of the things that has been initiated by the federal government under two federal things, they're called CAPTA and CARA, and they're basically laws that protect children, which were recently updated in 2016. And as part of that, one of the things is called a plan of safe care. And this was a requirement of the states to have a plan in place for infants and children with parents who had a history of substance use disorder, and particularly for babies born with neonatal abstinence syndrome. Also fetal alcohol syndrome, which is actually tied into this as well. So one of the things that you can see from this, there's a lot of people that need to be involved in developing a plan of safe care. And Pennsylvania is really struggling with this, and we still don't have a plan of safe care. We're struggling even with the definition of what neonatal abstinence syndrome actually is. Yeah, so the definition is, there's each hospital system seems to have a basic definition, and the Department of Health is giving more guidance, but it's still, how do you test it? How do you screen for it? There's a lot of times it's not very clear. And the screening, there's different screening tests out there, so the state has not designated an official screening test for this particular population, and they haven't designated what the counties are really supposed to do, which is what our regional task force are trying to make up for. And so, but as you can see, it involves a family, it's childcare, it's the correctional system, it's housing, it's evidence-based home visiting, which is like things like Early Head Start, Nurse Family Partnership, and what we do, Healthy Families America. And parents as teachers are the 4 programs in Pennsylvania. There's medical care and home care. Transportation is a huge issue in these populations. Early intervention services, so they would be the services by the county. Drug and alcohol treatment, behavioral health, and all of this has to go into the mom and the baby and the family, and who's in charge of it. And you can see it's a very complex problem. And of course, no funding. So there's a lot of behavioral health challenges, and we'll get into this a little bit, but we just wanted to really highlight what we have seen, particularly in our Safe Start, and we've just done a big study on this. So, as I said, we know that pregnant women are suffering from substance abuse disorder, but they also are dealing with chronic medical conditions too. And so we're looking at, they can have hypertension, diabetes, obesity, mental health conditions, lots of things that really make it even more complicated. It's not cut and dry that the mom has a substance use disorder. Okay? And we say substance use disorder because this is a medical condition. It's not a choice. Just like people don't really choose to have diabetes or other medical conditions like cancer, this is really a medical condition. And so the stigma around this is really part of the problem in getting money and funding to really treat it. So where we're at, Governor Wolf has declared heroin and opioid epidemic a statewide disaster emergency. He issued that on January 10th, and that's a 90-day proclamation that gives the state more resources to really start addressing this and getting Pennsylvania out of the top 5 nationally. But there's 13 parts to what the governor went. I'm not going to go into that. My biggest thing, and they are trying to address that, is what I call data, because although we have some data, a lot of it is around the people dying, but we don't really have a good number of how many people are actually administered Narcan, how many people are repeat Narcan, how many people are going into treatment centers. We have some Medicaid data that tells us that, but we really don't have a lot of data on other insurances that is collected by the state and analyzed. We also are lacking a lot of information about pregnant women. Many pregnant women are afraid to even, go for treatment or help, or even to admit they're pregnant until late in their pregnancy because they're afraid that the county will take away their other children or take the child that they're pregnant with. And there's a lot of other issues of even getting them basic help and medical care. We'll again go into that. One of the things around that is really becoming evident in the 2-generational impact is really that what I call the 3rd generation is that the grandparents are the ones now taking care of a lot of these babies and children. And so we don't even have good numbers on that. And how do we address and help people that we don't even know how many is there out there? And who's reporting that, who's helping them, who's giving them funding to do this? We don't really know. And then we're halfway through this proclamation. There is, the governor may have the right to redo it for another 90 days. During that time, he has been documenting more of the things that I just talked about, the data points that they're trying to look for, and to see if they can at least get a point in time number. But they really need to invest heavily in more data and research in this, and it needs to be publicly accessible. In order for this to really work for agencies like us, I have to go through a lot of hoops to get the data that I use, and sometimes it's filing right-to-know requests and things like that. And in this epidemic, we really just need to know what's happening. And that is my part. So I'm going to ask our panelists now if they can just kind of give some of an overview from their perspective. You want to start here?
Sure, that's fine. Hi, good afternoon. I'm Melissa again, and I'm the Safe Start Program Director at NCC, and I manage our high-risk programs. And I want to touch on, I work specifically with pregnant women who have substance use disorder and also high-risk pregnancies, as well as babies who have neonatal abstinence syndrome or have been exposed to opiates. And I want to talk a little bit more about something Rose touched on, which was the kind of enormous amount of needs that these families have. And she talked about the plan of safe care. And it's something that we're really seeing that is so important. If someone doesn't have stable housing, how are they going to get into treatment? Or if they don't have transportation, how are they getting into their prenatal care? If they have a mental health issue as well as substance use, which most often they do, how are they getting out of the door if they have crippling depression? So there's all of these needs, and we need, kind of coordination to help bring all of these things together. And we need the systems to communicate together. So something that our programs have aimed to do is work directly with the major health systems, as well as the insurance companies and behavioral health providers, to get everyone on the same page so we can not duplicate. If one person is doing referrals for this and connecting to this, then we try to support that, and also making sure like we're all meeting together to try to address the care for these families. Another thing that Rose addressed was the stigma that pregnant women have in families, and it's something that we're seeing across the board. When we first initiated these programs, especially with the Centers for Excellence, which I'm going to talk a little bit more in a second, people imagined that we would find hundreds and hundreds of pregnant women, and that has been kind of a struggle. And one of the main reasons for that is because they're not getting into prenatal care. Often they're just showing up at the ER to have their babies. They haven't been followed by any medical provider. And so we don't reach them until after their babies are here and their babies are in the NICU, and then we're meeting them and they have a lot of needs and not a lot of support. So I think being able to see pregnant women in a holistic way and understand the nature of addiction, and something that I think is very, very important for everyone when we're thinking about substance use, is to understand the impact that trauma has. All of the women that we work with and the families we work with have years and years of generational trauma, and that affects their behavioral health. It affects who they decide that they want involved in their life and in their care, and it really affects the way that they access care. So not just health care, but behavioral health care. A lot of our women have been in the system, in many, many systems, over and over, and don't feel like they have been heard. And so I know through the Centers for Excellence, but also definitely at MCC, we're trying to empower women to have a voice and to create goals for their families and support them so that they can navigate their health care and their recovery in a different way. So I'll talk a little bit, that's what I think is important. It just touches a little bit of it. So I'll talk a little bit about what MCC is doing in the Centers for Excellence before I pass it on. The Centers for Excellence was implemented by the state, and they imagined, and there are 45 Centers for Excellence currently across the state, and everyone does things a little differently, but the goal was kind of what I was talking about before about collaboration of systems and care to address opiate use disorder, but to have major health systems and community organizations as well as behavioral health all work together to try to work with people. So we're at MCC involved in 2 Centers for Excellence, one at Temple, that program is called the Temple 2 program, and one at Penn, which is called the Mothers Matter program. And what those programs do is they provide drug and alcohol treatment, mental health treatment, and it's paired with prenatal care for pregnant women, and we provide community health work. So we call our community health workers at MCC advocates, and we go into the community, we partner with women, we go with them to their appointments, we help them prepare for their appointments, we provide emotional support and goal setting and linkages, we communicate directly with their providers, and so we also meet with the other systems weekly. So we're constantly talking to their drug and alcohol counselors and and the people who run their group. We're talking to the doctors who they see for their prenatal care, and we're all working together to try to come up with goals and best assist these women. And these programs are doing this across the state, not just for pregnant women. The Centers for Excellence were implemented for anyone with opiate use disorder. And at MCC, we are doing the COEs, we're doing programs working with high-risk pregnant women as well, but we just started a new program called Healthy Babies, which is following babies who've been exposed to opiates. We We often meet those babies when they're already in the NICU, although our goal is to try to work with women when they're still pregnant, like right before they have the baby. And we are following that baby up to a year, and we have the ability not to just work with mom, but anyone that comes in contact with that baby. So if the baby ends up going into placement, we'll work with that caregiver. If they go to kinship care or foster care, and we'll continue to work with the parents. So we're really trying to work with everyone who is involved with baby. If mom needs to get into treatment, we're gonna work with her to try to get into treatment. If CYS or DHS is involved, we'll work with them as well to facilitate those conversations. If reunification is on the table, we're really going to try to help work with mom with that. Making sure that babies get to well visits. That's something that the hospitals we've worked with have identified as a huge issue. Babies come into the NICU and are screened for opiate use, and then they're sent home, and then there's no follow-up with the NICUs or the doctors who saw the babies afterwards. So we're trying to provide that follow-up and that care, and we're communicating in the same program with the NICUs directly, so we can say, we went with the baby to this well visit, we know who the caregiver is, this baby has this appointment with this cardio person or whoever, and we're really trying to bring everyone together. I think with all of our programs, it's important to have a team approach to working with families. So that's all for now.
I'm not sure if I'm going to need a microphone or not. Can you hear me back there okay? I'm a little more comfortable. As introduced, my name is David McKeighan, and I'm the Executive Director for the Delaware Co.Medical Society. Joe, it's nice to see you again. It's been a while. Joe used to work together with me in the Delaware County Child Death Review, which was among our more morbid things that we did. But back then we were every quarter looking at every child under the age of 20 that died in Delaware County, trying to find out why and how, and what could we do as a community to try to avoid those things. So my involvement with the Medical Society was formed a little bit even before the League of Women Voters. We go back to 1850, although I haven't been with them the whole time. It kind of feels like it some days. I am privileged, though, to work with the physician community here in Delaware County, and have really made the most of it, trying to get us as involved as we can in our community. I have a little bit of an organized ramble I'd like to go on here as we look at this whole epidemic. And when I phrase it as an epidemic, I hope you know what we mean when we use that term, because that's a serious term. When we say epidemic, we mean it's not getting better. We're not winning this fight. Things are getting worse. They are worse than they were this time last year. Rosemarie gave some good stats about how many losses we've had throughout Pennsylvania and throughout the country. I did check in with Dr. Hellman this morning, and he tells me that in the year 2015, only 3 years ago, there were 204 deaths in Delaware County to overdose, and 168 of those had opioids. In 2016, it progressed by about 10%, and we had 227. In 2017, so far, 271. Now, when I say so far, there are some people who died in 2017, and we do not yet have a final ruling as to how they died or the cause of death. We know it may have been overdose, but we don't know if it was an accident, a suicide, or something even more suspicious sometimes. Dr. Hellman's often thought of in this community as kind of the canary in the coal mine. He's been out in front, and 15 years ago, I can remember hosting a press conference with then District Attorney Patti, and we were talking about this drug that we hadn't heard of yet called oxycodone. Since that time, the oxycodone has gotten a lot of attention. People are aware that it's a very powerful and very, very excellent medicine for pain, but it comes, as a lot of other good medicines do, with some risks. So one of the last things I'm going to say at the end is that we need to rethink how we look at pain and our whole cultural approach to pain. I'd like to keep rambling, though, if I may. Go for it. Task forces. Yes, we have a task force here in this county that's very active and coordinated. It was founded by our past District Attorney, Jack Whalen. Our new DA will be running our task force. It encompasses a lot of folks from law enforcement, from treatment facilities, from medicine, and a lot of different stakeholders. There are many stakeholders in this epidemic. It also goes to family members who are affected. And I've got to say that when we lost 271 people in this county last year, I have to help you appreciate who they were. Because this isn't like the old days, back when we talked about drug addicts on Skid Row and problem areas. This is cutting across all cultural barriers, across all socioeconomic barriers. It's not necessarily a black issue or a white issue, it's a community issue. I think you know that. I think you've probably seen it. I know you've seen it on the news and the newspaper. It is one of the most important things facing our community these days. You mentioned stigma, and you mentioned stigma, and thank you both, because in my opinion, stigma is at the bottom of what's wrong with things. Why can't we as a community see someone with a behavioral health disorder or with a substance abuse disorder? Why can't we see them the same as we do someone who's physically ill with the flu or a broken arm? I'll come back to that, I always do. A lot of people get blamed for this, and that's not unfair. There's a lot of blame to go around, certainly. The pharmaceutical companies, the doctors, the pharmacists, everybody seems to have some blame. And I don't know if that helps us or not. Sometimes it helps us to feel better. Clearly, there are a lot of things going on. This county is suing pharmaceutical companies for their role in improperly convincing physicians that these drugs were not addictive. That's appropriate. Especially if the outcome to that is that they bring money into our state that helps us get more money for treatment. That's what's good. You mentioned for Centers for Excellence. Yes. These are treatment facilities that are set up, 46 of them, I think, across Pennsylvania. The one you didn't mention is the one down in Upland at the Crozier-Chester Medical Center, also a center of excellence for folks with substance abuse disorders. You'll hear me say those three words together a lot. I like to say that, substance abuse disorders, because I don't like it when people continue to refer to people as drug addicts. I think that just feeds into the stigma of it all. I said the doctors were also to blame, and I'll step up to the plate and say, yes, there have been a lot of doctors that have operated pill mills, and law enforcement has fortunately been able to shut most of those down. That was greed, and that was improper, and it cost a lot of people a lot of time, money, and lives. We've been promoting safe prescribing guidelines for physicians and dentists and oral surgeons for a couple years now. Rosemarie and I have worked together with the College of the University of the Sciences to put on proper prescribing programs, and we think that we're turning the corner on that, we hope. We don't like it when a physician or a surgeon gives you a prescription for a lot of pills when you only need a little. Government gets involved and sets rules on things, and it sometimes makes it better, but sometimes it makes it just more complicated too. One of the best things state government has done in the last couple of years is to institute a program that we call the PDMP, which is the Prescription Drug Monitoring Database. And now, if you are a physician and you want to write for oxycodone or any schedule narcotic for your patients, before you write for it, you have to go onto this database and you have to see wherever else this patient may have also gotten the drug. It's geared towards trying to cut down on the folks that were doctor shopping, and that you'll hear to this doctor and to this doctor, and very often, as I'm sure you're aware, they wouldn't take all these pills, they were reselling them. There's tremendous street value for some of these drugs. So that's moving along. We're trying to educate people more about this and how to really talk to patients if they discover that they have been seeing multiple doctors. One of the really alarming things I learned a couple of years ago, and we've been giving a heads up to a lot of people, but there's a whole cadre of people out here in Delaware County who on Sunday afternoons go around to real estate open houses, knock on the door, and boom, right up to the medicine cabinet to see if there's any drugs there. That's just the tip of the iceberg in how creative these people are in their drug-seeking behaviors. So you really have to be in touch on that. Anybody out there heard of Narcan? I think that's been in the news a little bit. I'll tell you, Delaware County is kind of the Narcan capital of the United States right now, in that this county was really the first to provide Narcan with all first responders. All ambulances, all police officers in Delaware County carry Narcan. They've administered Narcan successfully close to 1,100 times in the last 2.5 years. That's bringing a lot of people back, no doubt about it. It's given them a second choice. We now have an awesome program here in Delaware County for what we call a warm handoff, which means after a patient gets Narcan on the streets of Havertown or Bryn Mawr or Upper Darby or wherever else, they get a knock on the door the next day and a visit from a social worker who's a certified peer recovery specialist to try to help them get into treatment. And that's great. We'll have the success rate somewhere between here and there, and we're going to measure that real soon. I believe in that work, though. You mentioned the dangers with some of these drugs, too. The fentanyl and the carfentanil are incredibly potent things, and we worry a lot about first responders. If they roll onto the scene where there's an overdose, or perhaps it's a law enforcement raid on a drug dealer, I want them protected, no doubt about it, and they need to know what they're up against. So we're working on some training for these first responders. Rosemarie mentioned something we call MATs, or medication-assisted treatments. I'm sure you've heard of methadone. That's been around for 50 years, and people have used it as a substitute for when they wanted to recover from using heroin on a regular basis. There are other real good medication-assisted treatments that Rosemarie can tell you a lot more about than I can, because she's the one that's the pharmacist. But our goal is to get people to better embrace that and not have stigma about that. If you have a dependency problem, meaning that the use of some of these drugs is interfering with your life or putting you at risk, then medication-assisted treatment, in addition to counseling, is a real good thing for you to consider. That's something that I hope people will take and mention to family members and friends. Check out medication-assisted treatments. Delaware County, we also have something called safe disposal sites, and they do throughout Pennsylvania now. I left some flyers back there on the table, but in each of our municipal police offices, I know there's one about 100 yards from here, where you can properly go dispose of prescription medicines. Now, it's not just narcotics that they're interested in. I'd like to see people dispose of outdated antibiotics there. I don't really want to see us flushing it all down the toilet, because that gets into our systems and can't be good for us either. Delaware County's been out in front on that too, and I credit our county government for that. The other handout I have for you, if you like, is a copy of the quarterly magazine from the Delaware County Medical Society. And I chose this edition to bring a bunch of copies because there's a great article in here about what we are trying to do on a regional basis. Now, by region, I mean southeastern Pennsylvania. Rosemarie and I and several other people from Philadelphia, Bucks County, Montgomery County, Chester County, and Delaware County started about a year ago on this. Since that time, we've been joined by folks from Camden County and Newcastle County also. So we really have a good nucleus, and it's our goal to learn from one another. What is the best practice? What works here, and how can we take advantage of that? What data should we be sharing? How do we know and work together? That's a challenge. We're certainly doing pretty well. We just had our fourth in a series of regional meetings up in Bucks County 2 weeks ago, and we had about close to 100 people come out. And it's a great mix of people. It's folks from pharmacy and medicine, hospitals, law enforcement. We had the DA from Bucks County that did the greeting for us, and it was well done. We've also been meeting with folks from the insurance companies, knowing that they have a lot of data, and that they also take this whole epidemic very seriously. They've studied it, they have their own task forces, and we're really getting to know and getting to ask them to adjust some of the things that may be barriers for people to get care. So that's been going well. This magazine, as I said, is published quarterly. If anybody would like to sign up and get a subscription to it at no cost to you, we are happy to mail that. We mail this magazine on a quarterly basis to every physician and every dentist in Delaware County. We send them each two, one for the waiting room, and we try to use it as a patient education tool. Joe, it's published by the same publisher that does your magazine for the Delaware County Bar Association, the Hoffman Publishing, and they're great to work with. Next quarter, we're going to have an article that we're going to share in both about the whole emergency services plan for the county. So stay tuned. Suggested reading. I have a book that I'd like to tell you about that makes a lot of sense to me. It's easy to find because it's on the bestseller list. It's available in paperback, and it's called Dreamland. And Dreamland was written by a forensic reporter in California. And basically, it talks about how we get into this crisis as a country. Keeping in mind that it's a twofold crisis. It's one of prescription drug abuse as well as street drug abuse coming together in what really is a perfect storm. As I said, this book is written by a forensic reporter, so it's very interesting. The chapters are each about 3 or 4 pages long, so it's a good quick read, and you can put it down any time. But it talks about Mexican drug cartels as well as Purdue Pharmaceuticals. So it really hits home, and I encourage people to read that and share that. One or two other little things I have. There are some things out there that make some people more vulnerable to this than others. There's no doubt about it. There are conditions that we kind of think of behind the scenes in terms of a predisposition for addiction. It's easier for some people than others. What's important, though, is regardless of how you get into a situation, if you are dependent on life-threatening drugs like this, you've got to get help. You've got to have people around you. You have to have friends and family members and somebody that's willing and able to put it all on the line and say, this isn't going to be easy. I think the average amount of times that people enter a rehab before it really works for them is much higher than we're happy with. I think it's probably 3 or 4 or 5 or 6. Some families are just devastated because their loved ones are in need of money to fund their drug needs. So they steal everything in the house, everything that's not nailed down, the silverware, the jewelry, everything. You're at risk. That's why the earlier we can intervene, the better. So I don't know if anybody has any questions. I, as I said, rambled a little bit and didn't want to touch too much on anything. We can get caught up on any of these topics for a half hour or so. Yes?
You touch a little bit on a recent information that non-prescription drugs, combination aspirin and other pain relievers in combination can be as effective, if not more effective, than these opioids.
That is not only a great question, it's a current one. That study came out yesterday. I'm sure you either heard it on NPR as I did or...
And there's a lot tied into so a lot of times, and I'll just put this out there, a lot of times people need the opioid post-surgery, but most people will eventually need more and more opioids because your body gets used to them. And so the guidance now has been revised that, really prescription opioids longer than a week post-surgery for most people is not needed. That people at that point do just as well on, an Advil, or a Tylenol. And the other thing that they're finding is that people that do meditation, you're much more up to date on that, but like mindfulness and those types of therapies actually find more relief than people that continue on a prescription opioid long term. And so that's good news that we have other therapies. But there are other times, and this is what concerns me, and I'll just say a personal thing. So my mother was on hospice for a long time, and she definitely was opioid dependent. And by the end, she was needing more and more opioids, but she was in a great deal of pain. So, we have to balance what can realistically work for some patients and what can't. And so hospice patients are really worried now that they might not be able to get what they need to be comfortable in their families. certainly don't want to see people in pain. So, we have to be careful of this knee-jerk reaction too, that opioids are evil and they should be eliminated from the face of the earth. That's not true either, because they do have a place in medicine. They just have been way overused. For example, in Pennsylvania, in 2015, there was a 60-day supply of opioids dispensed for every person in the state. So there is a lot of opioids out there, and many people, I often as a pharmacist would hear people say, the doctor gave me 30, but I only want 10, that kind of thing, but, there's no refills on those types of class 2 narcotics, and so doctors would just write for a higher amount because they didn't want to have to write over the weekend, and you can't call them in and all this stuff. The other thing I just want to put out there, because David mentioned it, it's a really good point, I don't want to lose it, just regarding Narcan. So there is a standing order on the Pennsylvania Department of Health's website for Narcan. Anybody can download that and take it to a pharmacy and get Narcan if you think you have somebody in your life that could be at risk. And there's special trainings that you can also do that's free. So if you think that you have somebody, a cousin, neighbor, friend that you're worried about, go get the Narcan, because that could be the difference between them living or not. The other thing I want to say is around pregnant women. So just to clarify, so pregnant women can't stop using an opioid while pregnant, they'll lose the baby. Okay, so we have to continue them on a medication-assisted treatment through their pregnancy. So having them stop abruptly is the wrong thing to do. They really need to be in treatment right away. And so part of the reason that we have the high neonatal abstinence syndrome numbers is that 80% of those women are on medication-assisted treatment. So just to clarify that number, which is a good thing.
Yeah, I would like to have you address the question of why the number of opioid users is increasing, and I assume that it is increasing all the time. Is it because people are in more pain? Is it because the opioids are a wonderful thing that, if we all knew what the effect was, we'd run out and get hooked immediately? I mean, what is it that is increasing? I mean, you've alluded to the fact maybe it's because doctors are becoming less honorable. Maybe it's because pharmacists are greedier. Maybe it's because I don't know, and I have even less idea now
I'll
than
say
I
one
did
part.
when the panel started.
Yeah. So the one part to that is back in those of us in pharmacy could remember it. So when I was in pharmacy school, opioids weren't used a whole lot. They were really reserved for people that were in intense pain. And then it became this movement, and I'm sorry, but it was driven by the pharmaceutical companies, really pushing that no one should ever be in pain. That's what we were trained to say. So I went to plenty of
And
continuing
that's the
education.
pharmaceutical companies that put
Yes,
that?
the pharmaceutical companies promoted this idea that no one should ever be in pain. That it was not, so that rating system of is your pain 1 to 10, that was developed by the pharmaceutical companies. And that was developed to see, and if you said 7, they had actual measures and we were all trained to use them, and we were told that no one should ever be in pain. And of course, no doctor or pharmacist would want their patient in pain. And then the potency of the medications began to dramatically increase. So around 2000, those of us in pharmacy and toxicology saw the train wreck coming, and nobody was listening to, this might not be a good thing for our populations. And so the potencies from that point on really started to become dramatically higher. And so we're looking at long-acting, short-acting, things that and there could be some reasons for that, and we had more and more opioid dependent patients, especially again because people were living longer and things. But again, the potency didn't make sense to a lot of us. And,
Is it the
and that
major
was a big-
pharmaceutical companies, or are you talking about individual pharmacies and individual pharmacists?
the pharmaceutical industry promoted this idea,
The industry.
and the healthcare professionals, we're relying on them to provide us with good data and information, and to some degree, that was part of the problem.
In the
But
book
there's
I
multiple factors in this, and I'll let David say
In the
something.
book I mentioned, there's a great exposure to all of that. And it's one of the reasons I like to present it. It was pharmaceutical companies, certainly. I'll tell you, health insurance companies are also somewhat culpable. They have for years been asking you, how do you evaluate this hospital? How was your stay at the hospital? Did your doctor properly treat your level of pain? We've been conditioned and we've been brainwashed almost that says you can be sick and have no pain. 3 years ago, I had a knee replacement. Needed it, put it off for years and years and years. And it was a pretty difficult recovery that I don't know if I would have had the guts to do without my oxycodone. Before I went to physical therapy, my physical therapist was saying to me, take 2 in the morning before you come, and then take 2 when you get home. He also, though, insisted that as soon as I stopped physical therapy, I stopped using oxycodone, and that was quite responsible. They are great medicines, but we've been convinced that we don't have to have pain, and it's just not so. You mentioned that initially it was for cancer patients, people with unbearable pain. Right now it's so widespread, we have an epidemic of what they call opioid-induced constipation. Because there's so many people out there that need a new drug to get over that part.
They turn to concrete.
Yeah.
Been there, done that.
Does any other questions? Go ahead.
This one.
Yeah, you called it a substance abuse disorder. Is there research into any physical or organic reason why some people become addicts and others don't?
Another great question. Yes, there is. Yes, there is. I can tell you that they describe a substance abuse disorder as a pattern of use or misuse leading to significant impairment or distress. So it's kind of our way of saying to people, as you said so aptly, this is not a choice. This is a disease that people have when they are that dependent on narcotics like this. And it needs to be treated as a disease to get past it. So,
And there's also genetic links.
Yes.
There's significant genetic links that the research is showing. Just like the research has showed for alcoholism, that there's familial history of
depression.
that. But that, yes, and
Because I think, that would make people more sympathetic to the whole.
right, and they're also looking at the links, and maybe you want to say, with mental health disorders.
Yeah.
There's a
Yeah, just what you rarely see substance use without a mental health component, and this just goes back to the stigma as well. Like if someone is not going to get treatment for mental health, and they're going to find other ways to cope, often they don't have the support networks like we've talked about. Like they don't have friends and family who are going to step in and try to help support them. So people have to find a way to cope. And I think also that I mentioned this before, that it goes back to trauma. And so many people have witnessed and experienced trauma, their families, their parents, their grandparents, it's in their communities. And this is something that is not, this affects everybody too. And it's not talked about enough. So I think all mental health and trauma directly impact people's substance use disorder.
Yes.
How successful have our new certified drug counselors been in getting people to enter programs, rehab programs?
I can't quote anything for the record for you, but I have followed it carefully ever since our county has done it. And I recall Dr. Vedian telling me that about 20% of the people that they've tried to get in had actually gotten into rehab. And I thought, wow, 20%, not much, but when you look at that, it's huge compared to where we were before that.
Yeah.
And I think as these
Is
folks
that
get...
because we don't have the facilities, or because we can't, the people won't go into it?
We have the facilities now. It's that hard to get people to commit to change.
Oh, you
Keeping in
have
mind that when
losing
people are involved in
jobs.
these hardcore use of illicit substances, it's all they do. It's what their life is. It's a matter of getting high and then getting high again the next time. And they're not motivated to change. They're not scared. You can't scare them straight. We've learned that.
I'd be scared if I had to be black.
In the follow-up to Joe, you said, how much is it a situation where there aren't facilities or there isn't insurance or another way to fund it? It seems like, you keep hearing that, oh, there's only 20 days of this or you can't get this, so there isn't time to fix things. And so are we sort of saying we're doing something, but are we really doing something that works?
We can talk a little bit about that. I think there are a lot of rules, and I think insurance companies and the counties kind of can dictate how much treatment people can get, but also a lot of treatment facilities use the word compliance, and so like they set a rule like if you go to group this many days, you're compliant, but if you miss, we're going to kick you out of treatment. And then trying to get back into treatment is a huge process. And it really alienates people. And we were talking about motivation, like how easy is it to be motivated when you try and you show up, but then you don't do good enough, like what people say you should be doing, and you're kicked out. And so like at some point we're not really helping people. We see that a lot with our pregnant women. There's a lot of the programs that I work with. I don't know, imagine being 40 weeks pregnant and on methadone and having hypertension, and you have to go to group 3 days a week and 3 prenatal appointments a week and testing. But if you don't show up to your group, you get kicked out of treatment. Or you had a C-section and you don't show up for group for 3 weeks, you're kicked out of your program. So we don't make special arrangements, or we don't accommodate people when they're going through, it's not just the substance use, it's medical stuff, it's housing, it's transportation, it's family, it's social support, it's all these things. And we don't look at a person for, with everything that's going on with them.
Does the average, but does Medicaid or Medicare or just plain anybody's insurance, will that cover that sort of treatment? Or is this an out-of-pocket for the family on top of what they've already lost?
It really depends on the coverage.
Yeah, it depends on what insurance they have.
Yeah.
So there's a lot of issues with that. So, it depends if they're a dependent in the family, so depending on their age. It depends if they have private insurance themselves, and it depends if they qualify for Medicaid. And so, Pennsylvania is really trying to open up the Medicaid rolls more so that we can get more people into treatment. But then there's also limits on how many days you get in treatment.
Keep in mind that not all treatment means that you need to go away somewhere.
Right. So there's the
Some
medication
of the
assisted
most
treatment at home.
successful treatment is community-based.
Yes.
And
And
it's
you're-
laden with lots of different things to support that medication-assisted treatment.
Yeah,
So,
that's what the Centers for Excellence are really trying to do.
And
exactly.
moving to the community is really a big thing, and really important, particularly for pregnant women that have other children, because most treatment facilities do not allow you to take your children with you, and there's very few that even accept pregnant women.
Yeah.
So there might be a lot of other beds for other people, but pregnant women are such a special group that there's limited beds. And so they actually do better in the community, but think of that plan of safe care and what a mom has to do. So if she goes into treatment, like most programs you have to report a certain number of days a week or daily, depending on what you're getting. And then you have to bring your baby with you. And you have to pick up your other kid at preschool. And you have to show up at the county assistance office to apply for your WIC or your SNAP. And then you have to show them that you're going to have work somewhere in there. Like, there's some craziness to the system. And so, at some point, we have to admit that these people need a little bit of a pass to get better. And then we can expect them to do all the things we want in society. But
What portion of opioids are coming through legal sources as opposed to illegal? In other words, which are the legitimate pharmaceuticals and which are the drugs?
so that original one, the original graph that I showed you guys kind of talks to that. So with the prescription drug monitoring system, we have seen a significant decrease in the prescription opioids as being a cause of death and one of the leading and being one of the things that's on the street. It definitely has an impact, but unfortunately, it had one of those unintended consequences, so they couldn't get the prescription stuff, so they went to the street to get the illegal stuff.
Where is it now?
It depends on the area, and so like in Kensington, Kensington right now is really big on carfentanil. That's the big one. It depends on the geographic area who's selling it.
Here.
In Delaware County, I'm not sure. we'd have to.
It's a lot of
Fentanyl.
You very rarely see anything that's just heroin now.
Yeah,
It
there's a
almost
lot of
always
mix.
has fentanyl in it.
So,
But more importantly, you're also seeing the same person with heroin will have benzos,
yeah.
and
Remember when
will have alcohol,
Yeah, it's not.
and will have cocaine. And when they try to determine the exact cause of death, sometimes it's a polydrug death.
Yeah, and so they're not, oftentimes, what we're seeing, and what's the scary part now, and I don't know if you've seen, in Philadelphia, I was at one meeting recently, so what we're seeing is actually some new innovative drugs coming up on the market that don't even really have names. And so these are synthetic drugs that they're creating in some back room. And so we're not even sure what they are. But there's an increase, but we're going back to cocaine and other substances that are increasing on the market too.
And these heroines with additives are stronger than ever, more dangerous than ever, and the users like it because they get higher than ever.
And they're
they
being
keep
really
using
creative pharmaceutically, right? So they're taking care of your side effects. So they're adding in the things, if you're getting, heart palpitations, they're adding in benzodiazepine to release that, so that they're not pure substances, is what I'm saying. So it's not just one. These are very creative drug dealers, and they're creating products that are just downright frightening.
Could you address the safe needle for the safe injection site?
So Philadelphia, we were part of the, I wasn't, but one of our members from Maternity Care Coalition was part of the Philadelphia team that's looking into this. And so these safe injection sites in Philadelphia, the idea came from Canada. And what it is that there would be a safe injection site with medical professionals and counselors and people all on site. And that people can come in, you don't help them shoot up or anything, but you're there if something goes wrong, if they need Narcan, or the idea though, and it has been very successful in Canada, I know people don't like the sound of it, but the idea is that that's the opportunity to actually have a counselor or somebody try to convince them again to go into treatment. Like, that's the time that you can reach them. And it's a safe environment. It's, they're going to do this anyway. They're going to do it. They're going to do it in the back park or somewhere else. So, instead of finding them dead in your car, which happens a lot in Kensington, that at least they would be in a facility that we might be able to save some lives. Mm-hmm.
I think we've talked a lot about stigma, and I think that the safe injection sites are really an opportunity to reduce stigma around use. Because it allows, like you said, a safe place and really a bridge to care, hopefully. And I know it's a huge culture shift from how our society has viewed treatment in the past, where it's kind of all or nothing. Like the 12 steps, you're either using or you're not. But this allows for a middle ground, which I think a lot of people need. They're not ready to be abstinent yet. So I think it's important to look at recovery in a different way.
I'm not sure how this works. I probably should have read more about it. Do they bring their own drugs? I mean, they're not, yes.
So they don't sell them, they don't provide them, they can't provide any drugs except Narcan.
Okay, but it's working, they're actually coming. Why would they come to a place like that?
Because they don't want to die. They really don't want to die.
Okay.
They don't want to die.
It's safe, okay.
They know it's dangerous what they're doing, but their body craves it so much that they need it.
Another question back there.
Yep, go ahead.
So I would hope that you would put in a good procedure for your staff to have some control measures, such as there's only so many times you can come here and do this.
But
There's only so many times.
that doesn't work for them.
Well, when do they go in treatment? When do they become
So,
responsible?
And
So
this is
you
the
try
the
to
social
push-
work, but you're looking at it as a responsibility issue,
No,
and you have to
no.
look at it as medical, but
You-
people that work in treatment
you
can
gotta-
attest to
yeah, but
this.
if you
You
put
can't
some-
make things on them, they won't do it.
Look, and I don't think that's so true, because I've dealt with drug abusers. I've dealt with kids, teenagers, young adults, early 20s, mid-20s, mid-30s. No, you gotta put some sort of procedure in place, some sort of control system in, so that, I get having it and then they're attracted to it. So you're saying they don't want to die, so they are coming to these places to do a safe injection. And your goal is to get them into treatment.
Our goal
So
is to
there
keep them
has
from
to be
dying.
something to bridge those two.
Yeah, I don't know how you guys or me would deal with an ultimatum. I'm not good with an ultimatum. No, I understand.
But
I just think,
sure.
I don't think that's the purpose of this program. And I think a lot of traditional DNA, drug and alcohol programs, there is a lot of that kind of control in place. That is like the compliance stuff I was talking about before. You have to show up, you have to give a urine screening, you have to show up to treatment every 3 days. There is a lot of that in traditional treatment.
Well, that's what minimum treatment.
Right, but I think for the safe injection site, the purpose more is to create safety and a safe place for people to come, and then to start exploring the idea of treatment for when they're ready. I worry about putting controls in a situation like this and putting that kind of structure, because
And I don't think you might not have been here for the beginning, but I cannot stress enough, Pennsylvania we're in the top 5 of people dying, and we're not doing the right things. And so,
Philadelphia's top 4.
right, right. So we're not doing the right things, so we can't keep doing the same things that we've been doing and hoping that that's gonna fix the situation. It's obviously not working.
I think that she should understand, when people are addicted to cigarettes, to nicotine. I had a sister dying of cancer and would not give up her cigarettes. You're addicted, and no way of forcing that person is going to work. You are addicted.
You have to, the key to treatment, and I'm not the social worker, I'm nice enough to have 2 social workers with me, but the key to treatment, as I've seen it and I've been told, is that it's actually being there at the right time. And it's creating the environment. So working with our moms in these things, sometimes it's just keep offering it. It's like getting your kids to eat vegetables. You just keep offering it and hoping that someday they'll eat the vegetable. It's kind of the same thing. You got to keep offering it in the hopes that they'll grab onto this and get into treatment.
You never know what's going to turn the light bulb on for somebody.
Exactly.
So you keep trying all different kinds of things, because at some point, it's going to get switched on.
And I'm sorry, I know, I think that we're beyond our time. Sure. One more question.
Since you've identified these risk factors like depression, the genetic delay, trauma, is there any preventive public health education to the public that if you are one of those people who are susceptible to substance abuse disorder, I don't think people know that. I don't, so that if they have knee surgery or if they go to the hospital and you're getting drugs, so that you understand how to deal with this experience of getting these very strong medications.
I think, David, are they doing CEs for you? For pharmacy they are.
We're beginning to discover how we have to do that, yes.
Yeah.
Many doctors' offices now, when they prescribe an opioid, they will give you a separate little sheet from their practice that warns you about the risks and dangers. And I believe included in that is that within some families, there are propensities for you to become more quickly addicted than for others.
How do you know that?
You don't know that.
Well, there's
We don't have a lot
some
of-
genetic, but we don't have, you can't go to your doctor and get a genetic test. They're just now
You'll know
figuring
though
out
if you have a direct family member or
But if you have a family history,
a parent.
I don't know if had anybody heard of Jason Snyder speak? He'd be a great person, but he's in charge of the Centers of Excellence for Pennsylvania's DHS, I think it is. So Jason Snyder had 2 brothers that overdosed and killed themselves, and he also was in treatment. And so he's a great voice on this, but that's a family history. Like, he admits it, he knows it, he goes, I wish I known it sooner. When you hear him speak, it's really powerful. And I think, a lot of people can look, is there alcoholism in your family? Is there a history of depression? Is there a history of mental health illnesses? Because that's all connected. And we didn't even talk about incarceration, which is a whole other part of this. We have incarcerated mothers that we take care of in the Riverside Jail in Philadelphia. So who are there because of, a lot of them because of their substance use disorder. So
Jane,
it's
if you want
complex.
us to come back, we will. What can I say? This is not going to be something we cure overnight.
Obviously, this has been a wonderfully insightful program. Thank you all.